Welcome to this CAG webinar. My name is Verena Menek. I'm a professor at the University of Manitoba, and I'm also the Vice President of CAG. I will be moderating today's webinar. Before I introduce today's speakers, just a couple of things. First of all, and even though it seems like the last conference was just yesterday, I do want to remind people that the next CAG conference is October 22 to 24 in Regina. So please make sure to save those dates. The call for abstracts will be coming shortly, and you will be getting a mailing around that. Secondly, just a few words on the CAG Webinar Series. As most of you will know, CAG gives out a number of awards each year, and recipients are announced at the annual conference. This webinar series gives us a chance to actually hear from the recipients about the work or the contributions that led to them receiving the CAG Award. We also hope that the webinars will help to promote these awards so people can nominate their colleagues. Again, as you know, there are a number of awards given out each year. If you want more information, I'll direct you to the CAG website. You will find all the information around applications and previous recipients as well on the website. And just to repeat what Anthony already said, your microphones will be muted during the presentation so we don't get echoes or interference. If you have comments or questions, please type them into the chat box. If the chat box did not open up on its own, it's under that little bubble at the top right hand of your screen. I will be monitoring the comments or questions, and we will save the questions to after the presentations, where I will then ask our presenter to address them. So with that preamble, I'm delighted to introduce the speaker of this webinar. Dr. Matthias Hoben is an assistant professor in the Faculty of Nursing at the University of Alberta, and he was the 2019 recipient of the CAG Recognition Award for Excellence in Longitudinal Research in honor of Betty Havens. This award is provided to a CAG member who has demonstrated excellence in longitudinal research related to aging. With that, I will turn the mic over to Matthias. Matthias, take it away.
All right, thank you very much, Verena and Anthony, and good morning or good afternoon, depending on where you're located to everyone. And yeah, I want to thank CAG again for the honor of receiving that award and for the great opportunity to present some of my research here today. So the title of my presentation is Home Best for All? I'm going to speak a little bit about the assessment of intended and unintended consequences of aging in place policies. My research overall has focused on older adults throughout my career as a nurse as well as a researcher, and I'm really passionate about that topic. And you may hear that from my accent, I'm originally from Germany. I have been in Canada for a bit more than 5 years now. I've been doing my postdoctoral training with Dr. Carol Estebrooks in I will speak to that program a little bit further down in my presentation. So this slide really is just to remind all of us that everything that we talk about when we talk about research and practice of or care of older adults really is driven by demographic changes that have to do with increasing life expectancy. And Canada is well among the international players there. It's increasing, and it's well above 80 years at the moment. And another driver of everything we do when we talk about care of older adults really is dementia, right? While many chronic diseases have decreased as the reason for death in the last decades, dementia has drastically increased as the major reason for disease and major reason for mortality. And that adds to the complexity that we encounter in the system. And continuing care of older adults has been exposed to major pressures that health systems are dealing with. There is a report that just was recently published, very recently, about the future of it's a series of 3 reports about the future of long-term care, and one specifically focusing on the predicted costs of these developments. So I'm just presenting some facts as a background from these reports. It's evident that Canada, across all provinces and regions, is struggling to meet the needs of its aging population. For example, there are more than 400,000 Canadians that report unmet home care needs. And over 40,000 Canadians are on waiting lists for nursing home admission, and many of them in acute care beds, which really is not the right place for people with complex care needs that are not acute. And they're way more expensive than any nursing home bed or other care alternative. And then on the other hand, if you look into nursing homes, about 13 to 22%, depending on the study you're looking into, of the people living in these facilities have relatively low care needs that could potentially be met in the community. Of course, there need to be resources in place to meet these care needs. But if you look into the admission criteria and how complex people need to be admitted, there is a cohort of people who have way lower care needs than the actual admission criteria suggest. So we somehow don't seem to get it quite right. We have unmet needs in the community. We have low care needs in nursing homes where people should actually just be admitted if they're very complex. We have long waiting lists, and we have high rates of caregiver burden and unmet caregiver needs. And according to that report, the future doesn't look actually promising, right? So there is a huge number of people receiving any kind of ongoing care in home care settings, assisted living, supportive housing, retirement homes, also in nursing homes. And that number of people with ongoing care needs will increase by 75% by the year 2050. And while people in need of care will increase drastically, the number of caregivers available, especially unpaid family caregivers, will decrease substantially. And that's this graph here. That's really, especially the blue dotted line suggests the average hour of care that one family member, one family caregiver needs to provide, and how that's going to increase. So the number of caregivers will decrease, the number of people who are in need of care will increase, and that means the care hours that need to be provided by one specific individual will increase by 43%. And that's very likely not going to work, given the fact that family friend caregivers right now are already at their limits and very overburdened. So something needs to happen. And that has implications for costs. For example, the blue area here indicates how nursing home costs will increase, especially publicly funded nursing home costs. And the purple one is home care, publicly funded home care. And the green area suggests the added costs if the family caregiving now needs to be somehow be replaced because family caregivers are not available or can't do all the care anymore. So it has huge cost implications, but you can see that the biggest proportion of the publicly funded costs, the costs to the healthcare system or taxpayer costs, are really covered by nursing homes. And that proportion will increase. So the proportion of costs spent for nursing home care will increase drastically. So the pressures on the system are high already, and given these predictions, healthcare systems are struggling and are actually working very hard to do something about that. And one major trend across all Canadian provinces and territories really right now is, because of that huge area of nursing home costs, a shift from nursing home care to the community. And that trend really is called aging in place. It is not only driven by costs. There is also surveys out there that clearly suggest that older adults prefer to receive care at home for as long as possible, and that these home or community-based settings, these more home-like settings, are just something that not only meets preferences of older adults, but also is influencing their quality of life quite favorably. So there is two major drivers. It's the costs, and it's also the desire to meet older adults' preferences. Why communities or why governments have implemented aging in place policies. And these aging in place policies really have a whole bunch of measures that all somehow focus on restricting the access to nursing homes to people with most complex care needs. So defining specific admission criteria and enacting them. And then on the other hand, because then we have a backlog here to the community, to increase funding and capacity and services provided in the community to enable people to stay there. It is a major trend. It happens everywhere. However, we have very, very limited evidence on how successful we're actually doing it. So are these aging in place policies, for example, really able and successful to reduce length of stay in nursing homes? Are they successful in only allowing the most complex people in? And are there unintended consequences for families, for people in need of care, and also for the paid care staff? There's some evidence, but it's really very limited. And I'm going to present now on one of my empirical studies or a secondary data analysis that I did. And when I started to think about that study, I didn't have aging in place policies in mind at all. Like, that was just not within the area of my focus. Track focuses on nursing homes and improving quality of care there. And I actually was working on a completely different project. We were working on improving burdensome symptoms and inappropriate care at the end of life. And whenever you read a paper about like end of life care in nursing homes, at some point there is a statement somewhere that care of people in nursing homes has become more complex and their length of stay or their survival time has decreased. But if you look into these, if the studies cite references at all, very often there is not even a reference. It's just that statement that's made. People have become more complex, and that's why they don't stay as long anymore in nursing homes. But there is not a single study, even if a study is cited, that really has looked into these changes in length of stay over time. I found a bunch of studies, most of them US-based, and they really were just all cross-sectional. They may have covered a long time frame, but none of them has really looked how length of stay has changed over time. They really used the whole time frame as a cross-section and looked into length of stay. Then we have very heterogeneous outcomes. We have median length of stay, mean length of stay. We have a completely different definition of length of stay. Some of them just look into people who deceased. Some of them look into first admission to last exit up from the system. So you can see it's all over the place. It's very heterogeneous. And based on these studies, you can't really make that statement that anything has changed. We just don't know. There is a couple of longitudinal studies out there. They're methodologically weak. Many of them are outdated, and gray reports not even reporting sufficient details. And again, the patterns are quite heterogeneous, right? You can see there is a US study that somehow suggests that length of stay has decreased, but that's like in the early 90s or like mid 80s, mid 90s when that study was conducted. There is an Australian study that seems to be consistent. There is one report from Manitoba that doesn't report sufficient details to even know what they exactly did statistically. That seems to be a downwards trend, but you can't really tell. And the international studies here, they're like up and down, and it's all over the place. So that general statement that people have become more complex is not backed up by evidence. And at the time, that was bothering me. I was focusing on a completely different research area, but I thought, well, we have a longitudinal data set. Can we probably check that out, whether these statements are right and backed up by evidence and how that actually looks like in our region? And this is what that study actually, or how that study came together. So I just decided, well, I'm going to use our data to do that. And my research objectives were assess change in nursing home length of stay over time, stratified by residence year of admission. So the question was, if they were admitted in, say, 2008, how long would they on average stay compared to 2010, 2012, and so on, stratified by admission year? How long would they stay in these nursing homes? I was using data from Calgary, Edmonton, and Winnipeg because that's the 3 health regions that in our data set we have the most complete and most consistent data for over time. I also was interested in resident admission characteristics and have they actually changed over time, and if there is a difference in length of stay, Is that change driven by resident characteristics? And also compare these admission characteristics by region and year of admission. So I will give a little insight, not very comprehensively, but so enough so people can understand where the data that I used is coming from. I will give a little insight into TREC. So TREC's aims are to develop practical, evidence-informed solutions that contribute to sustainable improvements in quality of care, quality of life, and quality of end of life for frail, vulnerable nursing home residents. And TREC is also interested in quality of work life for the care staff who care for them. And TREC is a longitudinal program of research that's led by Dr. Carol Estabrooks, and she has actually started to think about TREC roughly in 2005, and the initial data collections in TREC occurred in 2007 and 8, and ever since there were survey data collections in nursing homes in a very comprehensive way ongoingly, plus the nursing homes that participate in TREC also provide TREC with resident data on an ongoing basis, and that's the RI-MDS data. I'm going to speak about that in more detail later. TREC is not only researchers. It's roughly 40 researchers that currently are in TREC across Canada, the US, and Europe. But TREC also includes trainees of all levels. And more importantly, there is decision makers from provincial and regional governments as well as health systems. There's owner-operators, residents, family, friend caregivers, care staff. They all are part of the team in different roles, and they are collaborating with TREC. So this makes this an integrated knowledge translation program. The core of TREC really is that survey study that I mentioned, and that's primarily collected in Western Canada. But TREC has some other projects that reach out to the north and to Atlantic Canada, and there are some attempts to expand the survey study to Atlantic Canada as well. And it's primarily for capacity reasons and not having enough connections that TREC has not expanded to Quebec and Ontario as of yet. So here is how TREC looks like. In the middle, you can see that survey data collection that I just mentioned, and I'm going to speak about the survey on my next slide. And together with the RI-MDS data, an administrative or routinely collected mandatory data set that's collected for each resident at admission and minimum quarterly if the status changes even before that. This together links to a huge database that TREC can use to do longitudinal research. And the data feeds into all kinds of things. It feeds into pilot studies, trainee projects, work packages. That means researcher-driven things. That length of stay paper that I'm just talking about was one of the work packages. System projects are similar, but they're not driven by the researchers. They are driven by our decision makers that ask TREC, can you actually do certain things? We have a question, can you answer them? Spin-off projects that use TREC data but then become an own entity driven by somebody else. The social network analysis that really was asking how are people in nursing homes seeking advice from others and how does that look like, and intervention studies. So that's pretty complex here and pretty comprehensive. The survey includes data on care facilities, certain characteristics such as owner-operator model, size, services provided, and so on. We also collect data on the unit level about the unit type, care staffing numbers on the care unit, services provided, and so on. And we have care provider surveys. We interview care aides, and we have an online survey that's self-completed by the regulated professions, nurses, allied health providers, clinical specialists, and managers. And the data we collect really includes organizational context, things like leadership, culture, evaluation, modifiable features of the work environment that are thought to drive quality and quality of work life. We collect care staff data on best practice use, their health, physical and mental health, well-being such as job satisfaction, burnout, work engagement, and of course, a whole bunch of demographics. And as I just mentioned, resident data And that includes really all kinds of outcomes such as resident functioning, diagnosis, social engagement, mental health, emotional well-being, very comprehensive data set that we can use and link to the other survey data sources. That's just a quick overview how TRAC has developed over time. In the meantime, in the latest wave of data collection, we have 94 nursing homes that include 339 units. We have over 4,000 care rate surveys in the latest wave, and there were a couple of thousands in the previous waves as well. We have almost 1,000 nurse surveys, allied health providers, and so on. And over 500,000 resident records from 55,000 individual residents across all waves. So this is basically the data set that I used to conduct that study. My cohort, first of all, included only 18 of the TRAC facilities because I wanted to have a stable cohort of facilities that participated on an ongoing basis since the first time TRAC started collecting data, to just keep things comparable. Residents admitted between 2008 and 2015. They needed to have an admission assessment, and the date of admission needed to be known because length of stay in that study was defined as a resident's first contact with the nursing home sector. So they needed to be admitted from somewhere else. If they came from a nursing home that we didn't have data for, we couldn't really tell how they looked like at admission. And the purpose was to assess from admission to their final discharge from the nursing home sector, how long did that take and what were the characteristics at admission. So that provided us with a cohort of slightly less than 8,000 residents from Edmonton, Calgary, and Winnipeg. And we did, first of all, estimates of unadjusted length of stay using Kaplan-Meier. We assessed how resident characteristics predicted length of stay. Then we calculated based on that, or estimated based on that, adjusted length of stay, so adjusted for all the important predictors. And also we looked into how these admission characteristics that are driving length of stay, how they changed over time. And this was a surprising finding here. This is a graph that illustrates the median length of stay by health region, Winnipeg, Edmonton, and Calgary, over time, 2008, 9, 10, 11, 12, 13, 14, 15, and the bands, the slightly lighter color, there are 95% confidence intervals of the median length of stay. And the pattern is pretty clear in Calgary and Edmonton, the two Alberta health regions, that length of stay has quite substantially decreased between 2008 and 2015. While in Winnipeg, and that was the surprising finding, it was higher all the time and there was no decrease. It was rather actually a slightly upward trend. That's not significant, but actually, at least it's consistent. So I started to wonder, like, does Winnipeg not have any demographic changes that are comparable to Alberta, or what was the case there? But anyways, I went on with the analysis and also assessed which of the resident characteristics were significantly predicting length of stay. And I selected all the different covariates based on available evidence. What do we know already is associated with length of stay or mortality in nursing homes? And the findings here are absolutely not surprising, right? Age, physical functioning, like all the red stuff decreases length of stay. If you're older, you're more likely to be early discharged. If you're physically impaired and cognitively impaired, you're not staying as long as somebody who's less physically and cognitively impaired, and so on. All the diagnosis, physical frailty and instability, BMI, a low BMI, if you need oxygen therapy, all these different things are associated as expected. And I primarily did that to see which variables I needed to adjust the later length of stay estimates, which I just illustrated here. The surprising finding comes in here. So one hypothesis was that nursing home residents are admitted at older ages because we try to keep them out of nursing homes. But that's actually not the case. It's all over the place, and it's not that residents at admission have become older over time. However, their care needs have become more complex. So the two regions, Edmonton and Calgary, where we saw that decrease in length of stay, in these two regions, we see an increase in high physical impairment, while Winnipeg was lower and consistent all the time. And the same is true for cognition. That was higher with a slight upwards trend, or in Calgary at least somehow consistent, while Winnipeg lower and decreasing. And the same for residents who are end stage or unstable. That is higher in Alberta with a slight upward trend, while Winnipeg is lower and consistent. So these things drive length of stay. And what we see here is that residents at admission just look very different in these health regions. And that made me ask, why is that actually? So let me just go back to that slide. I was having conversations with our policymakers, with some researchers who are familiar with things going on in these regions. And no matter who I talked to, they all said, well, that makes sense to me, because Alberta has implemented aging in place policies and has enacted them quite rigorously. They have increased their funding for community care and for assisted living, and they have split up the assisted living in different levels of assisted living, designated assisted living level 3, level 4, and level 4 for dementia. And there are many, many other initiatives going on in Alberta to really support people in need of care to age in the right place, but for sure trying to keep them out of nursing homes for as long as possible. And Winnipeg has these policies as well, but apparently they're not enacted as rigorously there. Winnipeg is the province in Canada with the highest proportion of people with low care needs at admission in nursing homes. And we do not fully understand why residents look so different, why policies look so different, and why they're enacted so differently. There is a team of researchers led by Malcolm Dube from Manitoba. I'm part of that research group, and they have started to look into that. And inspired by the work they're doing, I have started to think about my own research as well, and have decided that, well, now that I discovered these discrepancies, and there is the suspicion that differences in policies may actually be the driver or the reason for many of the different patterns we see, this is something I want to look into in more detail. So, if we know that in some regions length of stay decreases in nursing homes because residents become more complex, well, I think that has implications for all levels of stakeholders involved and all care settings, basically. If you increase complexity of residents, but then, as many health regions or many governments do, say that there is no money for increased staffing, well, that has implications, I would say. If residents become more complex, and maybe even like you increase the number of beds because you need more beds for these increasingly complex residents, but staffing numbers are pretty much the same, it has implications for quality of care and quality of work life. And there are also implications for the community, right? If residents become more complex there, the question is, are their needs adequately met, or are there unintended consequences such as unnecessary acute care admissions and readmissions, or sentinel events such as falls and other safety issues that may increase? We have some evidence on that out there. These are just two recent systematic reviews summing up some of the studies. One of them really focused on home care evidence of what works to support and sustain care at home for people with dementia, and another one was looking into also people living in the community, more with a focus on what helps to delay or avoid nursing home admissions. And while both of these found certain studies that provide evidence that a few interventions indeed work, most of the studies were really of poor quality, very narrowly focused on one individual intervention, not so much on a system level taking into account the different complex services that may be available, variability and uncertainty in outcome measures, lack of focus on the perspectives of people with dementia and the supporters. Also, as I just said, a failure to understand the complexities of living with dementia and necessary interventions. And primarily, the biggest deal is that the evidence available is really not very well suited to inform policy and practice. And then the other review found that single focused interventions, just isolated one intervention, like just home visits or just additional support or something like that, they were not effective in delaying or avoiding nursing home admissions. However, these complex interventions that looked into multiple different things, at least in the subgroup of people with dementia, they were effective in decreasing the risk for nursing home admissions. That study only included RCTs, so that was definitely not a policy focus at all. They were really testing these interventions in randomized studies, and there was no linkage to policies. And what I mean by that is, yeah, well, they implemented that intervention and it was effective. But my question is, based on the policies that we have in our governments and regions, the first question is, what services are actually available? Are there services that are similar to the ones that were tested in the RCTs or not? What kind of services are health regions actually implementing and enacting to keep people out of nursing homes? And to what extent is that reflected in the policies? Or it's maybe the other way around, looking at the policies first and seeing what they propose and then looking into the services and asking, well, how well are they aligned with what the policies propose and what do we actually have out there? And then once we know what the services are, then we can compare what the evidence is. Are they actually supported by evidence? And very likely not, because there is almost no evidence. But there is a lot of interesting questions to better understand how health regions do what they're doing and how successful they are. And this is a proposed study here. We're just working on the grant. It's going to be a project grant to be submitted in February. And that really is split up into 3 objectives. One of them is focusing on the policies. And when I say policies, I mean actually guiding documents that are developed and enacted by health authorities on a national, or governments and health authorities on a national, provincial, and regional level. We're not going to go down to the facility, institutional, organizational level, because we want to know what the health regions actually are doing to enact aging in place. So that's guiding documents such as regulations, policies, standards, recommendations, documents with different levels of legality, and that will be part of the analysis. What kind of level of enforcement do these documents have? There may be a document that nicely outlines what should be done, but nobody really enacts it because it's just not mandated, for example. So that's one thing that is highly interesting to know already. What's written? What are the texts that the different health authorities and regions actually are developing, implementing, and enacting? And most importantly, how do these different approaches differ across health regions and across provinces? Because in Canada, since ongoing continuing care is regulated by each province separately, there is a huge disconnect, and we almost have no idea how different provinces compare in what they're doing and how successful they are. So aging in place policies is one thing. And the second objective then is assessing possible intended and unintended consequences. And I'm going to talk about the set of outcomes that we're going to look into on the next slide, because there is a whole list of possible consequences that we could look into. And that's just not possible to include all of that into one individual study. So we have narrowed it down to a small set of outcomes, and I'm going to speak about how we did that on the next slide. But what we will do in Objective 2 is similar to what I did for length of stay. We will also assess these outcomes over time and see how they changed and how they differ between different health regions. And then in Objective number 3, we will, in a series of focus groups and workshops involving people with lived experience as well as decision makers and researchers, try to link objective 1 and 2 and try to understand why the different patterns that we see in the outcomes may, or how policies may contribute to these differences. So this is the proposed project. And we narrowed it down to 5 priority areas. And the criteria were A, they needed to be available in both Alberta and British Columbia, because that's the 2 provinces that we will focus on. They need to be available in administrative data sets in both provinces. And most importantly, we were checking in with policymakers from both of these provinces. We had a whole day meeting with them. We presented on the proposed project, discussed whether that is something that they would find beneficial and how to design that. And the most important part was a Delphi exercise with them to discuss and identify the outcomes that from a decision maker perspective, they're most interested in. They thought our priority to look into. So the single most important outcome that we focused on was living longer in the community. And that's basically complementary to the length of stay. In my study, I focused on how have things changed in nursing homes, but we will actually look into the other end as well. Have people actually stayed in the or received care in the community longer ever since these policies have been implemented. And we'll also look into assisted living. Another interest was on transition pathways. So one thing was really, how do people transition through the system from home care to assisted living to nursing homes or directly to nursing homes, and what are the different patterns? But transition patterns also include other things such as where are people admitted from when they move into a nursing home. And that was especially of interest to the Alberta stakeholders, because they realized at some point that very often the assessments for eligibility for nursing home placements were done in hospitals. And in hospitals, just people due to their acute situation are less functional and are more frail and sick than they might be in the community. So that resulted in nursing home admissions that turned out to be unnecessary. And that's why they implemented policies to really stop that. And whenever possible, the admission assessment for nursing homes should be done in the community. So when somebody's in the hospital, whenever possible, they should be discharged to the community first, and nursing home admissions the largest proportion should come from the community, not from hospitals. So that's another question. Where are people admitted from? And also, are there acute care admissions and 30-day readmissions, and do they differ across the regions? Then, of course, client health and well-being. That will use 3 specified quality indicators, such as daily or excruciating pain, depressive symptoms, and low social engagement. And we will also look into caregiver health and well-being and out-of-pocket expenses. And for that, we will use the Canadian Social Survey that just was released, the of it in 2018, and they have a very comprehensive set of variables related to out-of-pocket expenses, as well as caregiver health and well-being, and also about the client who was taken care of. So that's the 5 priority outcomes, and we will look into that in a similar way as we did for length of stay, and then try to, in the 3rd objective, link it to the policies and to understand how policies differ and how they contribute to different patterns. So yeah, that takes me to the end of my presentation, and I will be happy to respond to your questions.
Okay, thank you. It's Anthony here. We are just going to get Verena back on. It looks like you're unmuted.
Can you hear me again?
We can, yes.
Okay, thank you. I had some technical issue, had to leave. That's the problem with webinars. Anyway, I am back. Thanks very much, Matthias, for this great presentation, this really important work that you've been doing. While I was still on, we had one question that I will take first, and that is a very specific one. How is TREC funded?
Well, the TREC funding is a mixture of all kinds of different pools. Initially, the very first funding came from CIHR, from a big operating grant, and that has been an important source of funding all the time. Different research groups, like subgroups of track researchers, work together to submit grants and get funding, and that grant that I just was talking about will also be partly a track grant, and many track researchers are on that. We received a nice big grant just recently about using our track data to do comprehensive analysis on how organizational context is associated with quality. So many of that is really Tri-Council funding, primarily CIHR. We haven't tapped into SSHRC a lot yet. Some other sources as well, such as the Canadian Frailty Network, Alzheimer's, and so on. But that for a program as big as TRAC is absolutely not sufficient, because the infrastructure is getting bigger and bigger, such as like the database that we're hosting, the staff caring and maintaining for the data set, the managing director and staff, and so on. So that's pretty difficult to get funded on an ongoing basis, because it's just not innovative research, right? CIHR is not so interested in that. So we have gotten a lot of support from the health regions that we closely work together. We got bridge funding from British Columbia, Winnipeg, and from the Alberta government as well, and Alberta Health Services. So these are other funding sources, but all of that together is just not sustainable. And this is why TRAC is currently in the process of changing their funding model completely and changing their structure in a way so that things are maybe even kind of commercialized, so that we're able in one of the entities of TRAC that is disconnected from the research, because you can't influence the research in that way, but maybe sell certain services or hire people who are skilled in acquiring donations, and like it's currently turning into a business model more, and that's more something that the senior people in TRAC do. I'm not very much involved in that, but that's just the answer to that. It's a very complex system of different funding sources and models.
All right, great. Thank you very much. Okay, we have another question that is, will you be looking at the impact of dementia, given that the caregiving experience is very different from the perspective of the caregiver when dementia is present?
Yes, absolutely. That will definitely be a focus. We will, depending on the outcomes that we're looking into, but no matter which models we're running, be it length of stay or be it pain or anything else, we will stratify, of course, by cognition, or include dementia and cognition in the model as an important covariate, or do subgroup analysis. And very likely, if we look into caregiver burden, it will very likely, there is evidence already, right, that somebody who cares for a person with dementia just is more likely to have caregiver distress and burden, because it's just a very big task to care for somebody with dementia. Yeah, you're right about that.
Yeah, absolutely. Yeah. Another question here, will there be any focus on those older adults who have no support network?
Yeah, that is we have people doing research on these populations. They are hard to identify in these administrative data sets. This is one of the challenges. So within that research that we're proposing here, we will need to rely on administrative data sets, and to the extent possible, we might be able to filter them out a little bit. We've seen, for example, one of Dr. Estabrook's PhD students, Stephanie Chamberlain, has done work on the so-called unbefriended elderly in nursing homes. And she tried to use the raw administrative data. There are a couple of variables in there that can help us to identify people who don't have any family or friend caregivers. She specifically looked into people under public guardianship. And using that approach, we definitely can do subgroup analysis and look into those. It's not the primary focus of the research, and it's not going to be a too heavy focus, just because we will not be able to identify them too heavily. But there is research going on looking into that, and that's highly important for sure, yes, because they are a super vulnerable population.
Yeah, right, yeah. Well, thanks very much for that. Here's another question for you. Somebody is curious about the out-of-pocket costs, as many older adults will decline services as they do not have the money to pay for the services.
Yes, that's correct. Yeah. Well, again, the out-of-pocket expenses that are captured by the Canadian Social Survey really are based on reports from people who are in the sample, and they're like really split up by different, like, is it costs for driving somebody somewhere, or obtaining medications and stuff like that. So again, if we use that kind of a data set, we need to rely on what's in the data set. And I'm not sure if they have variables in there that indicate whether or not somebody was declined a service because they couldn't pay for it. But what's really important is when we do the policy analysis. And the policy analysis, I forgot to mention that, will not only be a document analysis. It will also be an analysis in conversations with our decision makers of what are the continuing care services concrete in your region that are available, such as rehabilitation or family support, or like all the different services, assisted living, a home care program, dialysis, whatever else. And for each of the identified services, we will have a semi-structured template to describe the characteristics of these services. And one of the important characteristics will be, how is that service paid for? Is that publicly covered? Is that covered by the Alberta healthcare system or healthcare insurance? Or does it need to be paid privately? Or is it a mixture of these different things? Is it maybe covered by additional healthcare insurance if you're employed? So we'll definitely look into, one of the categories will be, how is that service paid for? And it will probably turn out that many services that might be important for certain people are solely available by private pay. So this is how far we can get. The perspective that we are applying in that research is a system level perspective, not so much on individuals, how many individuals are there that can or cannot pay, but it's covered by what I just said, that we look into the services and identify how many are actually not publicly covered.
Mm-hmm. The next question is actually very much a segue on what you were just talking about. It has more to do with, are you also looking at whether those resources or programs are adequately funded?
Yeah, exactly. That's one of the questions. Yeah. And the question always is, who defines what's adequate? But we can definitely compare what the different sources are, and if it's privately paid, how much it actually costs, and how that differs between British Columbia and Alberta. And to start with, we're just looking into these provinces to keep it manageable and to develop the approach. But the objective certainly is to go beyond that and look into other provinces as well later on. And I think it's quite interesting, like, even now that we haven't done it systematically yet, turns out that, for example, in British Columbia, there is a huge sector of assisted living that's not publicly regulated at all. That's purely privately paid, and they're not even licensed, these facilities. So I can move in there if I have enough money and pay myself. But since it's not regulated and licensed, nobody collects mandatory data there. Nobody looks into the quality that happens. It's just really driven by me paying or just leaving because I'm unhappy. It's basically market mechanisms that drive that, and we have that in Alberta as well. But the number of facilities, or the size of that sector, is much bigger in British Columbia. So that's an example of the level we can get at in that study. So system comparisons.
Mm-hmm. Very complicated. Yeah.
Yeah. Mm-hmm.
And here's another question. Rural. What about the focus on rural versus urban, given that many programs and services are not available in rural areas?
Yeah, that's an excellent question. And we will definitely, since we look into policies and services as well as outcomes province-wide, certainly include that as an important variable. Was that in an urban region or a rural region? In Alberta, I can say that the urbanity and rurality is largely reflected in how the health zones are actually structured. Like the Edmonton and Calgary zones by default are urban zones, and then the north and the south zone are more rural. And this will definitely be a variable to be included when we do this, the quantitative models, but it will also be relevant to what extent these policies that we identify in these services are applying or are available in rural versus urban regions. Yeah.
All right, and just another question came in terms of out-of-pocket costs and whether that will include the missed income of caregivers who need to reduce their work time or retire to take care of a loved one.
Yes, I think that is a whole set of questions in the Canadian Social Survey, whether or not they had a loss of income or had to reduce their work hours. Yeah.
All right. Okay, great. And since I'm from Winnipeg, I'm struck by those striking differences in across the health cities in length of stay. So, and you briefly talked about it, and you know you're going to look at it more. But can you give me any sense of some examples, specific examples of what is different in the health regions?
Yeah, so I think the most important example really is how community services, especially that intermediate sector, the assisted living or supportive housing sector, how they are actually set up. In Alberta, they have increased the number of beds over time. They increased the number of the funding. They have increased all kinds of regulations around DSL, and they have facilitated people to move in these settings quite heavily before they move in nursing homes. So in Winnipeg, apparently, and that's another difference, first of all, that assisted living sector is not quite as big and it's not as differentiated as it is in Edmonton. But I think more importantly, and that is really the most specific detail I could come up with so far, if you look at the bed supply per population in the two provinces or in the two regions, then Winnipeg has the highest proportion or the highest bed supply, the highest number of beds per 1,000 people aged 65, 75. I can't quite recall the number anymore, but the highest bed supply of nursing home beds among the Canadian provinces. So if you have nice policies that tell or that try to keep people out of nursing homes, but these policies would lead to empty beds, well, empty beds are even more expensive than filling the beds with people who have lower care needs, right? So there seems to be an oversupply of nursing home beds, and to fill them, the system needs to accept that the people who are admitted there are not quite as complex as they would like to see it. So that seems to be one mechanism that really takes effect there.
All right, excellent. We're getting to the close of the webinar. And in response to the question, how can one access the slides? There's two answers to that. First of all, the webinar has been recorded, and so it will be available on the CAG website. So look for that in a few weeks. I'm not sure how long it takes to actually get it there. If you would like the slides sooner than that, I would suggest you contact Dr. Hoben individually, and can I speak for you that you would be happy to share them? Or okay, yeah. So you may want to. No, all right. So they can be shared in advance of the webinar being uploaded. So thanks again. Just a couple of closing words. Again, save the date for the next CAG conference, October 22 to 24 in Regina. And also save the date for the next webinar that we will have on January 23rd with Dr. Sandra Hurst, who is in the Faculty of Nursing at the University of Calgary, who was awarded the 2019 CAG Award for Contribution to Gerontology. There will be more webinars coming as well, so keep an eye on those and the mail links that will come out for the different presenters and the different timeframes. With that, thank you everyone for attending this webinar, and thanks again to Matthias for this excellent presentation. Thank you, and have a good afternoon or late morning as the case may be.